Okay, so here in x-axis, volume is taken, okay? In the y-axis, pressure. So here is a heart, okay? Just imagine this portion, okay? Or anywhere, any chambers, okay? Usually they will test only the left ventricle. They will compare the left ventricle pressure with the volume. They compare the pressure with the volume, fine? X-axis, it's the volume, and y-axis, it's the pressure, but anywhere. In x-axis, they can take the volume, and y-axis, they can pressure, okay? Always any graph question, usually this is students will panic on the if they see a graph, but the usual concept is going to test it, but it's going to be a new kind of graph in your exam. Many new graph, many new pictures, many new histology pictures, many new things comes in your exam, fine. So you should be ready with your concepts and with lot and lot of practice with UWorld or any question banks, fine. So here the volume and the pressure is taken, okay, and the lowest volume in the left ventricle, the lowest volume in the left ventricle is the end systolic volume, okay. First I want to fix that point in your mind. Here is the end systolic volume, okay. Follow the black ones, do not see any other arrows, okay. Follow only the black ones. Here is end systolic volume, this is the lowest volume. In the lowest volume, cardiac cycle, this is the lowest volume, end systolic volume. What is end systole? So at the end of systole, what is the volume present? At the end of systole, what is the volume present in the left ventricle is called the end systolic volume. End systolic volume, fine. And now, in the end systolic volume, the mitral wall is actually opening. Okay, so end systolic volume, the mitral wall opens and filling happens. Filling happens, okay. And in this filling is very important. It has got 3 stages, okay, very, very important. One is the passive filling, okay. Passive filling. One is passive filling. Number 2 is because of the atrial contraction, the filling happens. Maybe you can call it active, something like that. Fine. Passive, here, first stage is rapid and second stage is slow. Okay. First, when the mitral valve opens, rapid filling happens and then it slows down because the pressure drops, right? So slows down. And then active, I mean the atrial contracts and pushes the remaining blood. For example, say 80% of a blood is filled with the in the left ventricle with the just the passive filling. Why this is important? Because the S3 and S4 heart sound, most of the students will be having doubt in this S3 and S4 heart sounds. You want to understand this. How's the filling happening? One is rapid filling, the next is a slow filling, and then the atrial contraction, and then fills remaining, fine. And then here is the end diastolic volume. Okay, the maximum volume of left ventricle is end diastolic volume, and here the mitral valve closes. Okay, just visualize, okay, just visualize and have some visual memory over the heart, fine. And now this, okay, here is the left ventricle, here is the mitral valve closed, and here is the aortic wall already closed. Now the left ventricle starts contracting, okay. The left ventricle starts contracting without changing volume because both the walls are closed, right? Now the pressure rises. Now the pressure rises, fine, without changing volume. This is called isovolumetric contraction. Isovolumetric contraction. Okay, when the pressure here overcomes the aortic pressure. So here is the aortic pressure and here is the left ventricular pressure. So now the left ventricular pressure is increasing when it overcomes the aortic, aortic pressure. This wall opens and ejection happens, fine. So this pressure is going high to open the aortic wall, so blood moves out. Okay, so now ejection happens. First is rapid ejection. Ejection is so high, okay, and then slow ejection. The curve more flattens, right? So curve more flattens here. The curve has a very steep curve, and curve more flattens here. So this is rapid ejection because of more pressure here. Put more blood into the aorta, and then the blood slows down. Blood flow slows down. At here, the aortic valve closes. Aortic valve closes because the aortic pressure overcomes the left ventricular pressure here. So okay, the closes, and now both the walls are closed. And now the what begins? Isovolumetric relaxation. Isovolumetric relaxation. There is a big pressure drop here. Okay, now the left ventricular pressure here goes below the left atrial pressure, goes below the left atrial pressure. So the mitral wall opens. So it's just the play between the pressure. Wherever the pressure gradient happens, that wall closes or opens. Fine, understood? And how the question is framed here. Now focus on this blue line or the green line. This is what the question in the exam, okay? They can give you some 5 or 6 curves, okay? They can ask you the likely the curve in the options. For example, say, okay, before going to that, okay, I want to add one more point, the stroke volume. The stroke volume is nothing but end diastolic volume minus end systolic volume, because that's a part that is going into as the cardiac output. Okay, that's a stroke volume. Fine. So difference. Okay. Okay. So for example, this is a pathology. Okay, I'm coming back to the pathology later. Okay, here you can see the stroke volume is low. Fine. The stroke volume is okay. Narrow curve, narrow curve means low stroke volume. Fine. And one more point you have to be very sure is this contractility. Fine. For example, make some arrow like this. I mean, make a line like this. I make a line like this. Okay. Remember the Frank-Starling curve? The Frank-Starling curve where you use the preload and the cardiac output. Okay. So you'll get a curve like this, right? If I curve the move up, it's increased contraction. If I curve the move down, it's called decreased contraction. It's a decreased contraction, because if you increase the contractility, for example, you fix the preload, I mean the venous return, fix the preload and you increase the contractility, you can see increase in cardiac output. Fine. So this Frank-Starling curve explains that. Fine. That's also very important. They can, in the exam, they will ask about this end diastolic sarcomere length. Okay. For example, say if this is the muscle length you have, okay, you put some preload, I mean the venous return, this muscle stretches, I mean the cardiac muscle stretches and recoils back. Okay, when it recoils back, it pushes the blood. Fine. This is Frank-Starling concepts. Okay, now let me teach you some important pathology in the next page. Okay, so this is my usual technique I followed, because that's going to be very easy for I will share with you. Um, okay, so if I see this 4 graphs, if 4 types of graphs in the examination, the first thing I will note is the stroke volume, because that is going to give me easy classification in my mind. Okay, for example, the stroke volume for the stenosis state is going to be low. Okay, the stroke volume for the stenosis state is going to be low. This is going to be the first point that comes to your mind when you see the graph. You can easily get the graph in very quick manner. Okay, so in aortic stenosis or the mitral stenosis, there is going to be decreased stroke volume, number one. And the regurgitation state, there is going to be increased stroke volume. This page is damn important for your exam. You have got a lot of UWorld questions in the exam. Do everything and get the right concept. Fine. For regurgitation, there is increased stroke volume. Now, I'm going to give you some tips how to differentiate between the stenosis. Okay, now first point, you know the stroke volume, right? So decreased stroke volume, stenosis state, aortic stenosis or mitral stenosis. And now you want to note whether it's aortic or mitral stenosis. Note the afterload. Okay, the aortic stenosis, for example, here is a heart and here is the aorta. Okay, there is some stenosis here. Now the left ventricle has to create a greater pressure to push the blood into the aorta because of a stenosis. Fine. So the afterload is going to be so high. So the left ventricle has to create a greater pressure. Fine. See here, the left ventricle has to create a greater pressure to open up the aortic wall. Fine. This is aortic stenosis, main differentiating point. So just imagine, just everything is a visual memory. Fine. Just imagine you have a stenosed aorta and all of the blood is not going out. So you can see increased end systolic volume, increased end systolic volume. Fine. So what is the important point here? Increased end systolic volume and increased LV pressure. This too is a very important point to understand aortic stenosis. And about the mitral stenosis. Fine. Mitral stenosis, just imagine here is a left atrium, here is a left ventricle. Okay, here is a mitral stenosis. Okay, if stenosed wall is not allowing blood into the left ventricle, so that end end diastolic volume is going to be very low, because during the diastole the filling happens. What happens for stenosed wall? The end diastolic volume is going to be very low. If end diastolic volume is low, stroke volume is low. Fine. So always first note the stroke volume, it's low. Fine. Note the afterload, I mean note the pressure here is going to be high for aortic stenosis. Okay, and note the end diastolic volume here is going to be low, it's going to be mitral stenosis. Clear? And now the other two about the regurgitation and mitral regurgitation, mitral and aortic regurgitation. Here, the stroke volume is going to be high, and there is no true isovolumetric phase. Why? Just think of a balloon here. Okay, this is a balloon. Okay, okay. What if you like make some like a pores here? Will be moving out, air will be moving out, right? So the same concept. Okay, for example, here is a left ventricle, here is the mitral wall, and here is the aortic wall. Fine. If there is going to be regurgitation, and here you can see the regurgitation, but the main difference between the mitral wall regurgitation and mitral aortic and mitral wall regurgitation is, in aortic regurgitation it's during diastole, it's during diastole, and mitral, this is diastole, and mitral regurgitation is happening during systole. This is the very important point, because you would have confused this point in the exam or in the UWorld. Fine. So always remember the diastole or systole, and also the auscultation is going to be very simple points. If you have some doubts in the auscultation, I can clear you. Okay, so auscultation area is very important, a key for you in the exam, because most of the time they will give you the auscultation area, and also it's systolic or diastolic murmur, so they'll be giving you that. Okay, even you don't listen to the murmurs, you will be getting to the answer. Okay, let's see to that later, but let's focus on the pressure volume loop and valvular diseases by now. Okay, and now there is no true isovolumetric phase, that's important point, but how to differentiate? Okay, I said there is increased stroke volume, and there is no true isovolumetric phase for both. Okay, but what's the differentiating point is the ESV. The ESV, the end systolic volume for aortic regurgitation. Okay, here is aortic wall. If there is regurgitation, the end systolic volume is going to increase. The end systolic volume is going to increase. Okay, in mitral regurgitation, here is the mitral wall. If there is some backflow during the systole, there is some backflow into the left atrium, the end systolic volume is going to decrease. Understand? Clear? Okay, if you are clear, just show me a hand like this. If you're clear, yes, very good. Okay, so this is a best way to do this graphs. Fine, just focus on one or two points and just move on. Okay, and always remember, okay, one point I remember, a very important point, if this is the left atrium, left ventricle, whenever there is increased afterload, in the system, the left ventricle is going for concentric hypertrophy. Okay, this is concentric hypertrophy. Okay, and whenever there is volume overloaded state, whenever there is increased volume in the left ventricle, the left ventricle will be going for eccentric hypertrophy. This 2 points is damn important for exam. Fine, you can see thousands of questions, I mean a lot of questions in the UWorld. Fine, because they will play with the numbers. They will say like diameter of the left ventricle wall, they will say like left ventricle cavity or something like that. Fine, always note the thickness of the wall. If thickness of the wall is so high, then it's going to be the concentric hypertrophy. And if the diameter is very high but the thickness is not, thickness is normal, go for this eccentric hypertrophy. So what do you understand by this? For all the regurgitant state, there's going to be they're going to be eccentric hypertrophy. And for all the afterload increase after, say for example, very common case today's world, hypertension or aortic stenosis in the old age. Okay, it's going to be the concentric hypertrophy. Fine. All the stenosis state, concentric hypertrophy. Regurgitation is eccentric hypertrophy. But one point you will most likely confuse between this HOCM with the aortic stenosis or this concentric anything. Fine. Okay, this HOCM is also a hypertrophy state, but remember, this is the heart. Okay, so this is my usual mind map. Okay, for example, if I think of hypertrophic cardiomyopathy, I think of the interventricular septum. Fine. If I think of the aortic stenosis or the hypertension, I think of the concentric hypertrophy. I mean, even thickness, when the thickness of left ventricle is equally increased. But the interventricular septum is the main culprit for this HOCM. Fine. And also for the aortic stenosis, it's going to be age more than like 70 or something like that. And it's due to the calcification is the most wear and tear. Okay. And this can be in your exam. Fine. For example, this is the aorta, and here is the stenosed, okay, the stenosed wall. Okay. Why this is stenosed wall? Because of wear and tear. I mean, or during the age, as age increases, there is wear and tear problem, and that results in cell necrosis. Fine. And this necrosis leads to calcification. Fine. And if you see this aortic stenosis at a younger age, for example, less than 40 years, this aortic stenosis case, okay, it's not common. Okay, but what happens in bicuspid aortic wall? This can happen in bicuspid aortic wall cases. Aortic stenosis can happen in 40 years, but usually the most common is the age factor for this aortic stenosis case. Fine. So you relate all these valvular diseases with the concentric or eccentric hypertrophy, and HOCM, it's interventricular thickness, interventricular septum thickness is increased. Clear? Yes? Okay, thank you. Yes, who asked this question? So are you now, Komal asked this question, right? So are you now clear with the concepts? Have some practice in the UWorld, you'll be good. Okay.
Okay.
Yes.
Okay.
Next, what's your next toughest one?
Different type of shock and its physiological changes.
Sorry, I'm not able to get you.
Different type of shocks and their physiological changes.
Oh, shock. Okay, so let me go to my. Okay, first let's see first aid or whiteboard. Okay, let's go to my whiteboard. Okay, so listen carefully. What is shock? Shock. What is shock? Anyone, please?
Inadequate organ perfusion and changes related to that.
Very good. So inadequate organ perfusion, it can be due to, okay, high blood pressure, I mean low blood pressure, hypotension, but in some cases can be caused by some high cardiac output cases also. But remember, inadequate organ perfusion, I mean the definition is inadequate organ perfusion and oxygen delivery, nutrient delivery is insufficient. That is called a shock. Okay, there can be different types of shock. For example, say the obstructive or hypolimic or anything. Okay, let me give you some simple tips how to understand about the shock. Okay, here is a heart and here is the venous return. Fine. And here is a cardiac output. Okay, now any problem with the venous return. Okay, for example, hemorrhage. Okay, a road traffic accident or something, hemorrhage, bleeding, internal bleeding after surgery. Okay, any types of hemorrhage, the patient is going to lose blood, so the preload is going to be very low. When the preload goes low, the pressure, I mean, you measure the pressure in the veins. For example, inferior vena cava, you call it central venous pressure. Okay, central venous pressure is indirect way of measuring this right atrial pressure. Fine. You measure the pressure in the vena cava, and it's a pressure you associate with the right atrium. Fine. And when you measure the pressure in the capillaries of the lungs, it's called PCWP, pulmonary capillary wedge pressure. It denotes the left atrium pressure. Fine. If you are very clear with this, it's going to be easy for you. So for example, say if I say hemorrhage, the preload is going to be very low. So if the preload is very low, for example, just remember it's a closed chamber heart. If a preload is low, all the pressures inside will be low. The CVP will be very low. The PCWP will be very low. Fine. So for example, say if I say hemorrhagic shock, CVP will be very low, PCWP will be very low. Fine. Okay. What happens if I increase the, for example, say the relaxation of the heart? Okay. I put some fluid around the heart. I put some fluid around the heart so that the heart is getting a very tough time to relax. Tough time to relax. And now you can understand, for example, I'm talking about the cardiac tamponade case. Okay. In this case also, and the hemorrhagic shock or the hypolimic shock, the cardiac output is going to be very low and all the pressures inside the heart will be very low. In cardiac tamponade, if I put some fluid around the heart, there is very difficult to relax. So now you can think of the pressures inside the heart is going high. Pressure inside the heart is going high and cardiac output is going low. Fine. But what if I have obstructions in the pulmonary artery? Say, for example, here is a heart. Okay, here is a pulmonary artery. I have some obstruction here. Okay, now this pressure going high, the CVP going high. What about PCWP? Less volume on the left atrium, then the PCWP will be going low. Fine. Do you understand? No? Yes?
Can you repeat it, please?
Okay, done.
For obstructive.
1 second. I'll make a new page. Fine. Okay. First, okay, this is very easy to understand. This is hemorrhagic shock. The CVP is low, PCWP is low, cardiac output. If the preload is low, the cardiac output is going to be obviously low, right? Fine. And what is the next type of shock? Okay, obstructive shock. Obstruction to the, the outflow tract. Obstruction to the any obstruction to the cardiac, cardiac output is going low. Okay. Where is the obstruction? If it's going to be cardiac output, okay, think of the fluid around the heart. Think of a fluid around the heart. The heart is not going for diastole. So all the pressures inside going high, right? So CVP, PCWP going high in case of cardiac tamponade or say this tension pneumothorax, something like that. But what happens if there is some pulmonary embolism? Okay, here is the pulmonary artery. Okay, here is a pulmonary artery and there is some obstruction, okay, big embolus that's obstructing the pulmonary artery. So the blood going into the lungs low. Am I right or not? So the left atrial blood volume will be very low, the pressure is low. Do you understand? So the CVP is going high, the PCWP going low, and the cardiac output is low. Understand? Clear? Yes? Okay. You are Niran. Yes, Niran. I'm not able to hear you. Yes.
Can you repeat it again, the obstructive type?
Okay.
Because
In obstructive,
yeah.
just by now, think of only the cardiac tamponade case. Fine. Just think of cardiac tamponade. Okay. Okay. Before that, I'm going to recall one thing. Okay. So here is a venous return. That is the preload. That is going to the right atrium. That is going to the right ventricle. That is going to the lungs. And from the lungs to left atrium, left ventricle, here is a cardiac output. Okay. And now I say wherever, or for example, wherever I put an obstruction, the pressure is going to be an upstream, the pressure is going to be very high. In the downstream, there is going to be low. Am I right? So if I put some big embolus on the pulmonary artery and block it, fine. So just consider you put some big pulmonary embolus here, okay, and block it. The pressures here is going to be high. The pressures here is going to be very low. Pressures here is going to be very low. The cardiac output is low. Okay, now if I okay, I'll make some other thing. Okay, if I put some block in the lungs or left atrium or anywhere, okay, put some block. For example, say cardiac tamponade everywhere. The heart is not going to relax. Okay, so everywhere the pressure is going to increase. Okay, and as a result, the cardiac output is going to be very low. Why the cardiac output is low? Because there will be decreased venous return. Because the heart fails to relax, so there will be decreased venous return. So there is decreased cardiac output. Because of the pressure you give over the heart, pressure over the heart, the pressure inside increases and cardiac output drops. Now, do you understand?
Sir, I think in the UWorld there is a line that PCWP increases in cardiac tamponade. So
Yes,
I got
increases.
confused.
Yes, you are right.
PCWP.
Increases. Fine. All the pressure increases.
Okay.
Just imagine. Okay. Now imagine. 1 second. Now is a heart. Okay. And now, okay, just imagine a balloon. Just imagine a balloon. Here is a balloon. Okay. You put some fluid in the balloon. Okay. And now you are going to press the balloon. Fine. You press the balloon. Inside there is a fluid. Okay. What happens to the pressure inside? Yes.
Yes.
Pressure increases. Am I right?
Hmm.
Pressure increases. So this fluid, you put the fluid around the heart. Okay. This is like pressing the fluid filled balloon, and the pressure inside goes high. But why the cardiac output goes low here? Because why the cardiac output goes low here? Because if a pressure is so high, the venous return drops. Now, do you understand or not?
Mhm.
Clear? Yes? Kiran? Okay, done. And now what's other types of shock? Is it like cardiogenic shock? This is very easy to understand. For example, say heart failure case. Okay, CVP, PCWP. Okay, here is a heart. Okay, so here is a cardiac output. Now think of like the heart muscles don't contract very well. If heart muscles don't contract very well, the blood gets accumulated in the heart. Am I right or not? The blood gets accumulated in the heart. This is going to increase the pressure in all the chamber. Increase CVP, increase PCWP, and the cardiac output goes low. Clear? Do you understand? Yes?
Yes.
Okay. The main problem here is with the understanding of the pressure. Fine. Just imagine this is a chamber. Fine. If you put more blood volume, the pressure is going to obviously increase. Okay. Here you take a balloon, you fill the balloon with the fluid, fine, some water. And here you take another balloon, you have more water. Okay. The pressure in the first one is high or low?
Low.
Yes.
Low comparatively to
Low,
another.
right? So here the pressure will be high. Now I'm going to put you in another scenario. Now you take a balloon, you put some fluid, and you compress it. Now what happens to pressure here? Increases. This is the basic understanding, because we cannot go back to the physics of our high school and do it. This is kind of imagination you should have. Fine. Always do the imagination, okay? Because we want to stay just with the medicine. We don't want to go for the physics and pressure gradient and study there. Okay. So just imagine. And now if I compress the heart, for example, say cardiac tamponade, pressure is going to increase. Or if I accumulate the heart with so much of blood, say for example heart failure, the pressure is again going to increase. Now you do understand or not? Okay. Yes, thank you. And what is other? Is it septic shock, right? Okay, the main problem with the sepsis. Sepsis, the exact definition is dysregulated immune response to something. Dysregulated immune response. So there is going to be like vasodilation all over the body. The vasodilation is going to decrease the total peripheral resistance. Fine. So if there is going to be vasodilation because of inflammation process going on, say for example, a bacterial infection, okay, the inflammation, this puts a fluid out. There's going to be edema. There's going to be edema. Fine. So if going to be that edema, if there is going to be an edema, what happens if there is edema? The preload is going to decrease. I mean, the venous return decreases. If the venous return decreases, everything is going to drop. Fine. Venous return decrease, everything is going to drop. Now you have to understand about now you know the cardiac output. Okay, it's low for all the 4 cases. But what happens to this total peripheral resistance? I mean, the resistance. Now the baroreceptor concept. comes to play here. Okay, I'll finish the baroreceptor concept, okay, in a very simple way. Okay, here is a heart and here is a cardiac output. Okay, and think of baroreceptors here. These are all the baroreceptors. I put the medulla here. Okay, these are the medulla. Okay, and here are some nerve connections to the medulla, and you have sympathetic and parasympathetic centers here. Okay, if there is low cardiac output, if the cardiac output is low, question to you, what happens to the baroreceptor firing? Decreases or increases? If a cardiac output is low, what is happening to the baroreceptor firing? Is it increase or decrease? Very important UWorld point, and also in the exam also they can ask the question.
Increase.
Decrease. Fine. Okay, just imagine. Okay, so just imagine one thing. Okay, here is a nerve ending. So this is actually the okay. Here is a baroreceptor. The nerve ending is actually the baroreceptor. Fine. This baroreceptors will be always sending the signal to the medulla. Here is a medulla. Okay. This baroreceptors will be always sending signals. For the pressure is equal to 120/80. Okay. There will be like some signals. If a pressure is going to be like 160/90, there is going to be high signals, very high signals, lot of signals. So pressure is low signals. And now the medulla is a genius. If it get high signals, it will understand, okay, there is some increased pressure in the body. I have to reduce it. So medulla will think like that. If there is decreased signals, the medulla will think like, okay, there is decreased pressure. I have to increase the pressure. Okay, this is set point in the brain. There's set point in the brain for everything, for the temperature, for the blood pressure, fine, everything. There's set point in the brain. If they're going to be increase or decrease, the brain is going to control. Okay, if there is decrease, brain is going to increase. If there is decrease, brain is going to increase. Clear? Fine. And now, what is the medulla is doing? For example, I say low cardiac output. And now you are waking up from your bed. Okay, you are waking up from the bed. Okay, immediately there is a venous pooling in your legs. Fine. This will decrease the preload and decrease the cardiac output. And now, what the baroreceptor firing? Baroreceptor firing becomes low. And in the medulla, they have sympathetic and parasympathetic centers. If there is low signals to the brain, now the brain is going to activate the sympathetic and inhibit the parasympathetic. Fine. So remember all the receptors in the heart, you have beta 1 receptor in the SA node, AV node, and even in the muscles, you have beta 1. And the muscarinic receptors is in SA node and AV node, and very small, very few receptors in the muscles. I'm bridging to your pharmacology concepts, fine, because this concept is damn important. Okay, I usually remember this concept and this renin angiotensin aldosterone system, fine. It's like favorite questions in the exam, fine. They are going to love these type of questions. They are going to connect this with pharmacology, physiology, microbiology, pathology, and everything. They will connect this concept with everything, fine. Okay, so now think of this. Okay, and in the blood vessels you have alpha 1 receptors, right? You have alpha 1 in the muscles here. These are muscles, you have alpha 1. And now if there is going to be sympathetic response, there is going to be increased heart rate, increased stroke volume, what I'm around. So what I'm circling, so there's going to be increased heart rate, there is going to be increased stroke volume, this is going to be inhibited, and this is going to cause us peripheral vasoconstriction, increase in TPR. And also you have in the kidney, you have beta 1 receptor. This results in renin secretion. Renin angiotensin aldosterone system is going to get activated. All the brain will do everything to increase the blood pressure. Fine. That's why when you wake up from the bed, there's going to be increase in heart rate. That's going to increase cardiac output and maintains the blood pressure. Fine. And the opposite is also true. If there's going to be increased cardiac output, the parasympathetic is going to get activated. There is decrease in heart rate. There is not much muscarinic receptors in the muscles. So directly the stroke volume is not affected, but this increase in heart rate can always in 1 second. Yeah. Decrease in heart rate, this decrease in cardiac output. Fine. Decrease in heart rate, decrease in cardiac. If this parasympathetic is activated. Understand? Clear? Okay, done. Do you have any other doubts? What do you mean by high output cardiac failure? It's going to be another important thing. So I'm doing that in the CK also, in the step 1 is also there. Okay. High output cardiac failure. What is high output cardiac failure? Okay, so cardiac output is high. What does it mean by cardiac failure? Okay, just remember, I'm going to take some examples here. Okay, there is a lot of T3, T4 hormones in our body. Say, for example, hyperthyroidism. Fine. This T3, T4, what is going to do? This T3, T3, T4 is going to vasodilate the blood vessels. There is decrease in total peripheral resistance. I mean, the systemic vascular resistance, or say total peripheral resistance, is going to be decrease in SVR. Why it's decreasing? Because this T3, T4 wants to, I mean, this T3, T4 increases the basal metabolic rate of the cells. That's why it's bringing in more more blood to the cells, more blood to the cells. Fine. And it's because of this vasodilation, there is increase in cardiac output. So decrease in TPR, decrease in cardiac output. Now, why the heart has to fail in this case? Initially, there won't be fail, but on on periods of time, the heart can get failed. Why? Because this decrease in TPR and increase in cardiac output increases the preload. Okay, if there is more blood flowing in the system, there's going to be increased preload. So the heart will not be going to handle that much high preload, and consequently this heart fails. I mean, the contraction fails. If the contraction fails, you can see this pulmonary edema and this heart failure. Fine. This is called high output cardiac failure. This is also a very important concept in your exam. Okay. Any other doubts?
Sir, so it causes eccentric hypertrophy or something, like due to the high output cardiac failure, because it's due to the
Always think
pressure.
of either increase preload or increase upload. Fine. So here it's going to be high volume. Whenever you deal with high volume, is going to be eccentric.
Eccentric. Okay,
Fine.
sir.
And they will ask you about the sarcomeres. Okay, in the eccentric, the sarcomeres means the muscle fibers, right? The muscle fibers are added in a series fashion, series like the series fashion. Fine. And concentric is going to be like parallel fashion. Okay, that's going to be also an important thing. Let me explain that. Fine. So, for example, eccentric hypertrophy means the sarcomeres are going to added in series like this. Fine. Concentric hypertrophy means the sarcomeres are going to added like this. So this results in thick muscle wall. This results in thick muscle wall. This results in, I mean, the cavity, the chamber size is going to increase. Fine. The chamber size is going to increase in eccentric. The chamber size is going to decrease in, for example, if this is the, okay, if this is a normal, okay, eccentric will be like this. Sarcomeres add in series, this is eccentric, and the concentric will be like this. Fine. So this is systolic heart failure, this is diastolic heart failure. That also very important point. This is a diastolic heart failure. Why? It's very difficult to relax such a thick muscle, but it has got super contraction power because it has to overcome the increased pressure in the peripheral circulation. For example, say hypertension, there is increased pressure in the periphery. So this heart muscle has to create a big pressure. That's why the heart muscles is going thick here. But what's the problem here? There is decrease in compliance. I'm introducing this term, the most fearful term of USMLE step 1 aspirants is compliance and elasticity. Okay, there is decreased compliance because of increased thickness. There is decreased compliance and greater capacity to push the blood into the high pressure peripheral circulation. Say, for example, hypertension. So this is diastolic failure. Okay, in eccentric, because of weak contractions, going to be systolic failure. Now do you understand? Everything will be asked in the all these will be asked in the exam. in some way, even if it's not going to be direct question, it can be like behind the screen. Okay, always I told you, like behind the screen there is going to be histology concepts. I mean, histology topics will be like behind the screen. That's why histology like plays a very important role. Okay, these are all the histology mindset. You should have some histology knowledge in order to understand all the sarcomeres, muscles histology. Okay, and so many histology. For example, say if beta 1 receptor muscle, if I say beta 1 muscle is located here, there, so you should have, okay, if I say like alpha 1 receptors are present in the blood vessels, you should know the blood vessels having intima, media, and adventitia. The media is having the muscles. So in the muscles, smooth muscle cells, I can see this beta 1 beta 2 receptors, alpha 1 receptors, something like that. Fine, only if you have this histology knowledge, you will be like doing excellent in the exam. Otherwise, like you will be like passing your exam with some discomfort, but you will be passing, but with some discomfort. Fine, you have any other doubts?
ECG important for step 1 or not?
ECG, only like they can ask you this myocardial infarction for ST elevation, STD, that ECG is important. And the next ECG is they can ask you this AV block or any atrial fibrillation cases, okay? Or atrial fibrillation, atrial flutter, or they can ask you this Wolff Parkinson White syndrome, or they can ask you this ventricular fibrillation, Torsett D point, okay? And these are all some important things, okay? Cardiac arrhythmias, they can ask you the ECG, or they can ask you this conduction blocks, okay? AV blocks also very important. And number 3 is myocardial infarction. And sometimes they can go for this. Do you remember this cardiac tamponade case, the ECG for the cardiac pulses alternance, right? I think it's pulses alternance. In that case, very rarely can be the ECG. Fine, and other things, that's it. Fine. They sometimes they can ask you this pericarditis ECG. That's it. Okay. ST elevation, ST depression. Okay, that's pericarditis, right? ST elevation for pericarditis, ST elevation for this MI. Fine. And the other ECGs, they don't ask you. Fine. Then this RR progression or something like, they don't ask you all that. Find some basic ECG, and they will be commonly testing this atrial fibrillation ECG. They love that. Fine. Do you have any other doubts? Yes.
Did you talk about endocarditis?
Endocarditis. Okay, so endocarditis, there is some memorization stops in the endocarditis, but I want to give you some big picture here. Fine. Okay, so here is a heart. Okay, here is a heart. I'm going to draw the endocardium layer in the red line. Fine. So this endocardial layer can be infected. The endocardial layer can be infected. And remember, this heart walls is also have this endocardial lining. If you understand this big picture, it's going to be very simple. Fine. And now this heart wall, it's working all 24/7 for all 365 days, or for all the 60 or 70 years we live. This heart wall is working, right? So it can go for some damage. Fine, it can go for some damage. Okay, for example, if heart wall, okay, this is a mitral wall, if I have some damage here, fine, and there can be like all the hematology points like platelets, and then the fibrin, the RBC, okay, they form a clot. Okay, they form a clot, a plug. Okay, and this you call it as nidus. This you call it as nidus. Okay, and sometimes this nidus is loved by some bacteria like Staphylococcus aureus. Okay, and this viridin streptococcus. Okay, and all these bacteria, they love this nidus. This bacteria is going to infect this nidus. Fine, they are going to infect this nidus. But what's the problem here? Real problem here. Obviously, there are going to be some valvular dysfunction number one. Valvular dysfunction number one. What are all the other things? Okay, this nidus can break off. For example, a breaking off like this, They can go into the systemic circulation. They can block the blood vessels like this. Okay, since it's a very small particles, they block all the small blood vessels like the fingers for splinter hemorrhages or Janway or oscular lesions. In the lower extremities, you can see this Janway lesions. Okay, and Janway or oscular. Okay, in the first state, they will give like, this oscular, like ouch, ouch for oscular, and lower extremities you can see, or lower extremities you can see this Janway or something like that. Janway is painless. Okay, this is painless, this is painful, and Janway painless. So everything is this pathology block that can obstruct the blood vessels. The blood vessels can damage. There can be, you can see some rashes here. Find some dots here. Fine. Or if it's a brain, it's going to be the brain. Yeah. Okay. It's going to be the, if it's a brain, you can block the blood vessels and causes stroke. So now the memorization part. Now, if I have understood this, now the memorization part, they can ask you, okay, for non-damaged wall, I mean, the native means like, I mean, the original, I mean, not the damaged wall, the bacteria that is going to infect the normal wall. Yeah, normal walls. The bacteria that is going to infect the normal wall, which bacteria? Staphylococcus aureus. Then they will can ask you this, the patient is undergoing some dental procedure, and after 2 to 3 weeks, they got all these symptoms. Then that's going to be the virulent
Viridum.
streptococcus. They can ask you this, they can ask you this point. And then any things, let's see the first state for any other important points.
311.
Oh, yes, this is the one. Okay. See all the highlighted information here is going to be very important here. Okay. So infection of endocardial surface of the heart, that is endocarditis infective. Fine. Staph aureus is going to high virulence bacteria. It can affect the normal walls. Virulent streptococcus affects abnormal or diseased walls because it's a low virulence bacteria. And it's going to be some dental procedure or something like that. Okay. And this is the key. Okay. Initially, I find it very difficult to pick up this endocarditis case in the exam, but I fixed this point very strongly in mind. In the exam, if you see this fever with murmur in the case, that's definitely going to be endocarditis case. Fever, if you see this fever with some murmur, okay, they're asking you this endocarditis case. Fine. Fix that point in your mind. Okay. Initially, me too, I find difficult to pick up this endocarditis case, but then I found out this key, like fever with murmur. That's going okay. In the exam also, they will ask you this question. Fine. Endocarditis will be one question will be that. And then see this, all the images are super high yield. Okay. Rod spots or this Janway or Osler and the splinter hemorrhages. And this is the thing. And one more important part, remember the examination, they can ask you about this Liebman-Sachs endocarditis. Liebman-Sachs endocarditis. Okay. So, for example, listen, for it's going to be the heart wall. Okay, this is the heart. Okay, I think the okay, I'm considering this as a mitral wall. Okay, this mitral wall opens in this direction. Am I right? So the wall can usually damages in this. I mean, they will call as atrial surface of the mitral wall. So the wall can damage here. The wall can damage here. Okay. And if it's going to be the aortic wall, remember, if it's going to be the aortic wall opens in this direction, so the wall can damage here. But both the surface of the wall is damaged in some condition, like Liebman-Sachs endocarditis, and this is non-infective. This is non-infective. You will see this in this very big topic, SLE. Very important topic, SLE. Fine. So they will ask you about this Liebman-Sachs endocarditis. Fine. And about the prosthetic walls. Okay. If there's prosthetic walls, the most common organism is going to be staph, epidermis. If there is going to be some abuse, drug abuse case, injection drug use case, going to be the staph aureus case. Fine. And that's it. Fine. Clear. Actually, I've explained this point. Now I think you should be very clear. Endothelial injury, formation of vegetations, consists of plates, microbes on heart walls, wall regurgitation. That point is very important. So expect some wall regurgitation. Okay, what's the valvular dysfunctions? Common is going to be wall regurgitation. For example, say mitral wall regurgitation, very common. Okay, if this is a heart, okay, there is going to be the mitral valve regurgitation. Okay, that's very important point. Okay, and this embolism concept. Embolism going to obstruct anywhere and blocks the blood vessels, and diagnosis via multiple blood cultures. Echocardiogram, don't worry about with this point. You will do this in CK. Fine. Any other doubts?